So, first and foremost, before you begin any therapy, hearing loss has to be identified and it has to be treated. So, we know that we can talk about hearing in regards to its nature, its type, and the degree. Newborn hearing screening programs were like a game changer. So, before newborn hearing screening, it took like 1 or 2 years for the parents to realize that the child had a hearing loss. When the child, their other siblings or their peers were starting to talk and their child wasn't talking. But newborn hearing screening is just like a huge game changer because now we know within like a day of birth if the child has a hearing loss. So the NIDCD estimates that as many as 12,000 new babies with hearing loss are identified each year. Another 4,000 to 6,000 infants and young children between birth and 3 years who pass newborn hearing screening acquire later onset hearing loss. So the total population of new babies and toddlers identified each year with hearing loss is 16 to 18,000. So if you're going to work in a school, early intervention, there's a very good chance you're going to have a child with hearing loss on your caseload. So the Joint Committee came together in 2007 to make this position statement that all infants should be screened for hearing loss prior to discharge. People on the Joint Committee include, the American Academy of Medicine or Pediatrics, ASHA, the American Academy of Audiology, and different state leaders. And they came up with this 1-3-6 model. So 1 month, all babies get screened. 3 months, we have a diagnosis. 6 months, intervention has begun. So 1-3-6. 1 month, everybody's screened. 3 months, diagnosis. 6 months, intervention. And I've heard people even say it should be like 1-3-6 weeks, This is such a critical time. We really want to move fast with our diagnosis and treatment. So all states now require hearing screening, and they have different states have different degrees of early intervention. So New York State, we pay a lot of taxes, but we also have very good early intervention programs. And at this point, 90 to 98% of all infants are now screened. They're not allowed to leave the hospital without their hearing screening. So all babies born in hospitals are screened for hearing loss. Sometimes they're lost to follow-up, where they're screened and they fail, and the parents are asked to bring them back in, and they don't bring them back in, but that's a different story. So we have this effective early hearing and intervention program because we have newborn hearing screening, we have very good audiological diagnosis, and we have early intervention, culturally competent family support with a medical home, good data management. It's mandated by the government, and we have evaluation tools for our progress. There are currently 2 tools used to screen hearing loss: otoacoustic emissions and the ABR. Both methods are objective. That means the baby does not need to be involved. They are safe, they are non-invasive, they are quick, they are easy, and they have a relatively high degree of accuracy. So these things are awesome because we know within 24 hours or 48 hours, whenever the nurse or the audiologist does the test, whether or not a baby has hearing loss. Remember, I said this is the highest incidence of birth defect or difference. 1 to 3 babies out of 1,000 are born each year. Each well baby has a 1 in 600 chance of having hearing loss. 1 in 20 babies fail even one newborn hearing screening test. 95% are born to parents who hear. Remember, most of these disorders, most of the causes of hearing loss are recessive genes. So can have normal hearing, and it could be complete shock to these parents that their child has a hearing loss. And we use the ABR in the NICU. So the ABR is a better test than the OAE test. The OAE test up to the cochlea, and the ABR test beyond the cochlea to the auditory nerve. But the OAE is a bit less expensive, so sometimes it's done more often. So OAEs can be used for well babies because there's less of a chance of a neuropathy or a problem beyond the cochlea. Now, the person who screens, sometimes it's audiology students get these jobs. Sometimes nurses do the screening. When you do the screening, it's easy. It's like a note. There's, a handheld device that does it, and it will tell you if the baby passes or refers. So you want to keep trying to get a pass, but if you can't get a pass, then, you have to tell the parents that the baby is referred. And that could be, very upsetting time for the parents, very stressful because they might think that their baby has a hearing loss. When in fact, the chances of them having a profound hearing loss are only really 10%. Newborn hearing screening is great, but there are some, false positives or children that fail because they have fluid in their middle ear. So the fluid in the middle ear obstructs the ability to get a valid test. So sometimes babies will refer or fail. Most of the time, actually, they refer and fail because they have fluid in the middle ear, not because they have a more serious hearing loss. However, it is upsetting, so remember that these parents, when they get this news, it's not always easy to hear. I remember I said unilateral hearing loss is not benign, so a one-sided hearing loss causes later language, learning, psychosocial or attention problems, and mild hearing loss is not mild relative to its impact. So screening at 35 decibels, which is what these tests do, miss anything better than 30. So we have a large group of babies that are passing their newborn hearing screenings. They might have a mild hearing loss. So our newborn hearing screenings, even though they're really great, they can't test for a mild hearing loss. So there are two problems with their newborn hearing screening programs. One, we don't have a valid test of the middle ear for infants, so for newborns. So these newborns might fail because they have fluid in their middle ear. And two, it doesn't test for mild hearing losses. It's not sensitive enough for mild hearing loss. It could also miss later onset hearing losses. But it's the best thing we have, and it's pretty good considering what we used to have, which was really nothing. So children that have later onset hearing loss would be on risk factors associated with it include a family history of childhood hearing loss, the CMV infection, unilateral hearing loss, or problems with their oxygenation of their membranes. Again, we want to work on a developmental, not a remedial intervention. So the sooner we can catch the hearing loss, the sooner we can get the infant, the newborn and the infant on track developmentally with its hearing peers. So as a result of newborn hearing screening, 90% of children with hearing loss go into general education rather than special education by kindergarten. The emphasis is on family-child with the interventionist as a coach. And early intervention focuses on adult education. It's not necessarily the degree of hearing loss that affects the outcome. It's more about the duration of the hearing loss. So the earlier it's identified and the earlier it's treated with a cochlear implant has more of an effect and an outcome at this point than the severity, because cochlear implants can work, with all severities. So it's very important for families to know that they should use their hearing aids very early on, or their cochlear implants, so that the child can access sound, so that it stimulates and grows the auditory areas of the brain. We have to have thoughtful, intense, and ongoing auditory skill development activities to take advantage of developmental synchrony and the practice of hearing.